Hi, good evening and welcome. My name is Dr. Gary Howsam. I'm a GP in Cambridgeshire and Vice Chair for External Affairs at the Royal College of GPs. I'd like to say good evening and welcome you to the latest in our series of RCGP live discussion events, the aim of which is to let you, our members, know what the college have been up over the last few months to support you and your patients. You can put your questions to us tonight on hashtag RCGP Live on social media or write them in our membership forum. We've got members of our team checking the forum to make sure we don't miss any questions, and you can also post them under the YouTube feed and we'll be able to pick them up from there too. So tonight we'll be talking about the spending review. We're going to be discussing what was pledged in the Chancellor's speech yesterday, and I'm very pleased to say I'm joined tonight by 5 clinicians who are working in clinical practice, but have been invited onto the panel because they have expertise from either other roles they hold currently or have held previously. I'll ask them to introduce themselves to you in a moment. The spending review is obviously a political announcement, but I just want to say at this point that the RCGP is apolitical. I probably can't say with my hand on the heart the same is true of some of our panelists, so please expect to get a whole range of different opinions tonight, which I hope will enhance the discussions as we go through. Before I kick off, I just want to run through some of the top lines from what was promised in the spending review, and you'll have to forgive me reading from my notes. It focused on COVID recovery, supporting public services and bolstering the country's infrastructure. On COVID recovery, the Chancellor committed to £280 billion to get the country through COVID, including £15 billion for enhanced testing capacity and £2.1 billion for PPE. As well as further investment for vaccination, research, purchase and rollout, and we'll probably touch on that a little bit more later. £3 billion was pledged for NHS recovery, which should cover checks and scans, the backlog of care and mental health care. We heard some similar promises as we did with the Conservative manifesto this time last year. 50 more million general practice appointments and 50,000 more nurses, but not much detail. Social care got an expansion in pledged funding, including an extra £1 billion, and probably more on that later too. Was it sufficient? The Chancellor pledged to make sure that the UK is a scientific superpower, with £15 billion pledged for research. And on infrastructure, we heard commitments to build and upgrade hospitals, including £559 million to support the modernisation of technology across the health and care system. But what's behind these numbers and what does it mean for you and I as we sit in our practices and the care that we can give to our patients? I'll be on hand throughout this evening's discussions to give you some views from the college. But what I'd like to do now is go off and introduce each of our speakers, ask them to tell us whereabouts they're in clinical practice and what expertise and experience they're bringing to the debate tonight. So perhaps, Sarah, I could start with you.
Oh, good evening. I'm Sarah Wollaston. I'm back in clinical practice now, having had a break for 10 years, being the MP for Totnes, and I was also chairing the Health and Social Care Select Committee, but now back granted a sort of temporary licence to practice to help out over the COVID emergency.
Okay, thank you, Sarah. Simon Gregory.
Good evening, everybody. I'm Simon Gregory. I'm a GP in Northampton, and I'm involved in medical education. I'm Health Education England's Deputy Medical Director for Primary and Integrated Care, and therefore I lead on GP specialty training in England.
Thank you, Simon. Krish.
Good evening, everyone. My name is Krishna Kastraneni. I'm a GP in Sheffield, Yorkshire, and part of the BMS GP executive team, and lead on areas like premises, infrastructure, and education, training, and workforce.
Excellent. Thank you very much. And Paul.
Yeah, good evening. Thanks for having me on this evening. Dr. Paul Williams. I was for Stockton South in 2017 until last December. I currently work as a GP. I've been a chief executive of GP Federation in the past, and I seem to have built a career being a COVID GP at the moment in COVID clinics.
Excellent. Thank you for that, Paul. We lost you slightly there, and it was just a bit where you were talking about your previous experience as an MP. So if you could just cover off that little bit again for the audience, because we lost you.
Sure, yeah, I was the MP for Stockton South from 2017 until the general election last year. And I also sat on the Health Select Committee with Sarah, although at the time she was a Conservative and I was a Labour member. But we were and we remain good friends.
Excellent. Thank you very much for covering that bit. And Bex.
Hi there. Thanks very much for having me on. Nice to be with you, everyone. My name is Bex Fisher. I'm a GP in Oxford and I'm Senior Policy Fellow at our foundation.
Excellent, thank you very much. So I'll kick off with the first topic of discussion then, if that's okay. So the review commits us to funding for just 1 year. There was some multi-year settlements in there. It's another short-term reactive statement from the government. We're obviously facing understandable pressures from COVID-19 at the moment, but what do the panel think short-term funding like this helps in terms of the health service? And perhaps I could go to Sarah first and then to Paul to get their perspective, and obviously your experience from the Health Select Committee in the past.
Well, my view is that it would have been much better from the point of view of the workforce to have had a longer term view, so you could do much more strategic planning around the workforce. But looking at this as the big picture of the spending review, necessarily it had to be to a certain extent short term, because they don't know what's going to happen. We've got a huge uncertainty over Brexit, for example, and the extent of what's going to unfold with the pandemic over the coming year. But what was striking to me was that there is very little about primary care in this, and very little for public health, and I think that also the smoke and mirrors that you always get to a certain extent around government spending announcements is that they tend to sort of focus on NHS England, and so the other parts of the NHS budget, like the workforce, health, education England, and what happens with public health, certainly what happens with capital and social care, tend to get sort of pushed on one side. But as I say, from the primary care point of view, there's very little detail here for primary care.
Okay, thank you very much for that answer. And over to you, Paul, please.
Yeah, well, to start off with, I want to be fair to the government and say that this is in the context. We did have a 5-year settlement for health funding that was negotiated in 2018, and so that but actually, I think that's probably the only thing I'm going to say that's going to be fair here, or at least give the government credit. I think big picture for me is that COVID has exposed 3 strategic weaknesses. One was our lack of organisational resilience, and of course short-term funding for things like the workforce, only short-term funding solutions for estates and for and relatively small amounts of money into new technology aren't going to help our resilience. They're also not going to help with the massive backlog that we've got, and with the rate of funding that's been announced in the spending review, it's going to take 6 years just to clear our backlog. I think the second thing, so resilience is one big thing. I think COVID has really exposed the health inequalities in this country as well. And if we're serious about tackling this, then we don't just need sort of infrastructure projects, improving transport and building new buildings in the poorer parts of the country. We need proper investment in public health. And there was nothing in this spending review about restoring some of the cuts that there's been to early years services, for example. And then the third big strategic thing I think that COVID has exposed has been the amount of pressure that there's been on staff. The huge impact that all of this extra workload has had on staff. Maybe there's a bit there about improving the mental health of staff, but it was very vague, and we really need a huge effort, an NHS rescue plan almost at this point, to get ourselves back to the level that we were at before, and to build our staffing and build our organisational and institutional resilience for the future.
Excellent, thank you very much for those answers. And already that's thrown up a whole host of things. I've made a quick list here. So we've got workforce, Brexit, health inequalities, workforce wellbeing, public health, primary care, organisational resilience. Now, all of these things are really, really important to us when we're delivering patient care. Just before we move away from sort of your parliamentarian history for you guys, how much sort of knowledge do parliamentarians generally have on the impact that these sorts of statements are going to make to frontline clinicians, and how does that impact on preparation for the statements? Perhaps I could go back to you, Sarah, and ask that question.
Well, I think that parliamentarians do see an awful lot of issues around health and social care in their MP surgeries, but I think there's a very little understanding about the problems facing the NHS, and very little understanding about the impact of the workforce shortfall. So there's a tendency for people to focus on things like shiny new hospitals, for example, politically, things that the political priorities often completely divorced from what's actually needed on the ground.
Okay, and perhaps Paul, can I get a perspective from you on that question as well, please?
Yes, Sarah's absolutely right. The level of knowledge of most parliamentarians extends to their own experiences, which are often around how you get an appointment with a GP and what comes into their post bags. And there's a real challenge for us to better communicate the realities of the way that the NHS works to these people. I remember as an MP taking part in a debate on public health and the future of public health, and I gave what I thought was a sort of reasonably informed, intelligent contribution for a few minutes. I found most of the other MPs in that debate were talking about their local hospitals and about scanners and about machines. And I think we need to. We've all got a job to do to help educate and explain.
Brilliant, thank you very much. And just for the audience, we are getting a few technical issues with Paul's Wi-Fi dropping out, but we've got 99% of that one, so thank you, Paul. Bex, I want to move over to you for the next question, if I may, please. I mean, we've already heard that this pandemic hasn't just exposed health inequalities, it's actually widened them as well. And it's really important for general practice moving forward to help address these and try and level out some of these inequalities. We were disappointed at the college that there was no specific mention of immediate action to address the issues raised in the Fenton report about the experiences and health outcomes for the BAME communities. And there's no targeted funding announced to improve sort of socioeconomically deprived areas. So do you think this was a missed opportunity?
Gary, thanks. I mean, yes, it's the latest missed opportunity, isn't it? And I think it's particularly galling because the more rhetoric there is, the kind of bigger the gap becomes between the rhetoric and the reality. And I think we all know from bitter experience that if you don't sort of proactively and decisively take action on health inequalities and societal inequality more widely, the result will be that those inequalities widen. And we also know that if you underfund core services, the effects of the deficit are going to be felt the most in the communities with the greatest need. If we think specifically about general practice, we know, of course, that at the moment, general practice in the areas of highest socioeconomic deprivation is underfunded and underdoctored relative to need. That gap's been widening since 2010. If we step back more generally, because we know, I'm sure others looked for mentions of general practice in the spending review documents yesterday, they'll have found one, and it was in relation to the pre-existing manifesto commitment. So there wasn't exactly a lot for us to go on. So step back and look more widely. The 3 billion additional funding given to the NHS yesterday that was actually additional funding over what had already been announced is, we think at the Health Foundation, at least 6 billion short of what NHS England needs next year. The 1 billion for social care is pretty paltry, and of that 1 billion, the vast majority is going to be raised through council tax rises. And the Chancellor overlooked the opportunity to extend the £20 rise in universal credit beyond April. And of course, poverty is this fundamental driver of health inequality. So I think not only did we overlook an opportunity yesterday to actively target funding to improve outcomes, the set of funding arrangements that the spending review announced yesterday will actually make the inequalities worse, and I think that's a real shame.
Okay, so if I could just ask you a follow-up question there, Bex. If you had the opportunity to direct additional funding to one particular part of the health service, where would you have put the money?
I think, as Sarah and Paul have said already, the omission of public health yesterday was absolutely staggering. I think that's slightly context specific. If you'd asked me that question a year ago, I would probably have answered differently. But in the context of a pandemic, to not increase funding for public health when there have been such drastic cuts in public health budgets over the last decade, I think is pretty gobsmacking. So that's where I put it now.
Okay, and I think, Sarah, we were discussing earlier on, and you've got some views on this lack of investment into public health as well. I was wondering if you could just expand on those for us, please.
Well, I mean, what we've seen over many years now is a shift from public health into the NHS England budget. And so we went into the pandemic desperately underfunded to start with. So that was a real issue. And now, right in the middle of the pandemic, on top of all that, we've seen announcements about dismantling Public Health England. It really is quite extraordinary. And also, if you look at the way that directors of public health have been essentially sidelined right from the start of the pandemic in favour of sort of shifting over to Serco test and trace. It shouldn't be called NHS test and trace at all. And so, I think that the approach to public health has been really, very poor, I think, throughout this pandemic.
Okay, great. Simon, could I bring you in on that as well? Because so the community you're working in, I think all communities suffer from inequalities. How do you think it would have changed your day-to-day practice, investment in one particular area local to you that would have made a big difference?
I think GPs stepped up during the pandemic and intervened in our patients, but we get taught at medical school about the social determinants of health. Michael Marmot gave a fantastic talk at last year's conference on how we really haven't addressed health inequalities. Particular concern that I would have, and it came up in a paper that the College Council debated, is our homeless patients. Being in the centre of Northampton, we have a lot of homeless patients, and there were temporary solutions for them. But many of those are people with mental health problems, they're veterans, and the addiction services are just not enough for them either. So not only are people disadvantaged by the poverty, but then the Julian Tudor Hart's inverse care law applies writ large, certainly in Northampton, and I'm sure in inner cities and indeed rural communities up and down the country.
Okay, thank you. And Paul, would you like to come in on this one as well, please?
I think others have hit the nail on the head here. If we were going to be making investments, then those investments should have been in public health. I think in order to the evidence from Marmot is that if you're looking for long-term reductions in health inequalities, you have to make investments right at the beginning of life. And I would have liked to have seen restoration of health visiting back up to 2015 numbers, and a real help to reduce those inequalities that happen in the first 1,000 days of life. It feels as though this government is working to a political cycle and doing grand announcements rather than looking at where the evidence lies.
Right, okay, thank you. I did warn folks at the start, I thought this may get a touch political as we went through the evening, so I'm glad I gave the health warning at the start. Bex, we came to you first on this question. I just wondered if you wanted to say anything else as we wrap up and move on to something different.
Thanks, Gary. I guess just a final point, I think we're fairly united in feeling that public health has been overlooked here. As Sarah said, dissolving PHE in the middle of a pandemic is an interesting choice, to say the least. And Simon and Paul have just spoken about Marmot's kind of focus on the social determinants of health. One of the things I find most concerning about the dissolution of PHE is that there doesn't currently seem to be any plan for what happens to those functions of public health. There seems to be more clarity around health protection functions. And so I think not only is there potentially a huge funding gap, but there's just a huge gap in actually where are these absolutely fundamental things going to be held within our system. We don't have that answer at the moment, and that's staggering.
Yeah, and I think that's a worry for all of us, isn't it? Because there's the real dangerous stuff falling between the net, and as we get organisational change as well, and the time it takes to transition and new organisations to bed in now probably isn't the best time for these things to be happening. So I'd like to move on to a slightly different area now and bring you in again, Simon, if I may, because every budget has got concerns for the primary care workforce, and one really important element of that is around training the next generation. We've heard numerous surveys recently about staff being burnt out and emotionally bruised and tired, and we'll come back to the wellbeing side in a moment. Perhaps we can just look at training, and with your role in HEE, perhaps you could expand a little bit more on anything that pleased you or disappointed you yesterday.
Yeah, thank you, Gary. Could I firstly say, though, that I fully acknowledge the disruption that has been for general practice and how hard our trainees and educators and all the practices have worked. And I think we really, for a moment, ought to pay credit to our profession that stepped up. And I've seen some incredible commitment from our GP specialty trainees. And so often older generations criticize others. And I've heard so many things about millennials and such like, but nobody can criticize this generation. They have been absolutely selfless. But yeah, education has been disrupted, and it's been great to work with the college on solutions around the exam and such like. But we've really got to try and maintain education and training during this next phase to help with the deficit of that. But the SR, how will HEE fare? Well, the spending review allocates budgets to departments of state. So health education doesn't actually know what its position is yet. It's still unresolved. So I need to be slightly cautious about that. I'm positive that there's another 260 million on top of our current 4 billion budget. That 260 million is welcome, but it does only cover the expansion that's already underway. And that means further developments still are unresolved. And as my father spent much of my childhood trying to tell me that I could only spend my birthday money once, we can't spend that 260 million twice. And there are, for me, 4 elements that I still need to know are specifically funded for primary care. I mean, Health Education England needs funding for a lot more workforce, because we need a sufficient and sustainable workforce. But we've opened recruitment for 4,000 trainees a year, having just had our 7th record year in a row of 3,793. But we need funding for those trainees, and we need funding for sufficient educational resources to support them. Also, working with the college, we were planning to move to 2 of the 3 years of training being in general practice. I do think it's really important that GPs train with the patients they're serving, with the public they're serving, and on the health conditions that they see. So we really need to know that's funded. And we've got the 26,000 wider workforce through the additional roles reimbursement scheme. And it is very different working in general practice. We are expert generalists. We're handling uncertainty. We're handling complexity and comorbidity. And that isn't easy. And we need to know that workforce will be trained. And finally, we actually need the infrastructure to support them. And then all of that fits with you talking about the Wellbeing and Burnout. And as you know, Gary, I led the NHS Staff and Learner Wellbeing Commission, and much of what we reported on, our recommendations, were actually accelerated by COVID. But there's much more to do. I think it was Paul said that the workforce was exposed in one of his 3 things. I think this needs to be a hard reset. And it's not just a hard reset for the spending review, but I think we need to look at the environment we have in primary care, and in fact in the whole NHS, and look at how we look after each other, how we look after ourselves and our workforce. And I think that's a challenge for us. And I think we need more well-being support for primary care and for the NHS staff. We've had the clapping. Now we actually need some resources to look after us.
Excellent. Thank you, Simon. That was a really comprehensive answer. And part of the reason we've had these series of discussions is not just to highlight the challenges that primary care and general practice in particular have come across this year, but to celebrate the contributions that we've made to the national effort. And as you say, that's not just established GPs, but our trainees have had a really tough year. So thank you for highlighting the efforts they've made over the last 9 months as well. I mean, just to say, from a college point of view, we calculated that it would cost about £10 million to provide an occupational health service for general practice over the course of a year. And it's we'd really like to see greater investment in mental health support right across the system too, because it is so important, isn't it? I think we all said at the start of this it was going to be a marathon, not a sprint, but then people were running at a very high pace, and that's been for over 9 months now. And we're starting to see the effects of burnout and stuff. Krish, can I bring you in on this as well? And, this looking after the workforce, caring for our team so we can care for our patients is fundamental, isn't it, if we're going to carry on for another 6 months working at this sort of pace?
Absolutely, Gary. I think you hit the nail on the head there. So when this all started, the profession was already at a point where we've been working with underfunding and extremely high workload for a significant amount of time. And whilst we've adapted very quickly and turned into a new model of delivering care for our patients, it certainly is taking its toll on the profession. There are colleagues up and down the country who've actually been affected by COVID and are still suffering from the after effects of long COVID. But even if you didn't have that, the extremely high levels of workload and how it's affecting day-to-day working life, I certainly can't remember a time that I've been busier than what I am now. And it just feels relentless. And the point you mentioned earlier on about occupational health, general practice does not have a centrally funded comprehensive occupational health service. So there is the practitioner at health program where if you're struggling or you're about to break, that there's a bit of support. But as clinicians, I think we'd all agree that prevention is better than cure, and we really need to be investing in looking after people so that these situations don't arise or can be prevented as much as possible. And that is a huge concern to us.
Yeah, and I think it's really important to get the balance right, isn't it? Because, you know, I think we should celebrate the fact that so many of the challenges that the country's faced over the last few months, general practice has been the solution to help fix. But that's having a real toll on the workforce. Now, I think, Paul, you're working in some of the COVID hot hubs, so that's going to be a slightly different environment to what you were practicing in before. Can you tell us a little bit about how you've maintained resilience in what really is the sharp end of things at the peak of the pandemic?
Well, I think there's been an amazing team working with me, team of nurses, of reception staff. And actually, probably the most important member of the team is the cleaner, the person who, when I leave the room, moves in and makes sure that it's completely a completely safe environment for the next patient. We talk with each other. We make sure that we're debriefing. We're always making sure that we're sharing cases with each other as well. But it's a tough environment. It's we're learning a lot of stuff about a new problem, a new health problem, and we can't always help our patients, particularly those that are starting to present now with long COVID symptoms as well. And I think it's the main thing I encourage people to do is to take time off. You don't need to be the hero doing all of the work all of the time. You've got to make sure you have a balance between your home and your working life.
Excellent, thanks very much. And I think, again, acknowledging the role that everybody in the general practice team plays is really important at this point as well. None of us can do our jobs as doctors without our support teams, our administrative teams. And you say the people that come in and keep the buildings safe for us all at the end of each day and the start of each morning. So thank you for highlighting that. Whilst we're talking about buildings, perhaps, Krish, I can bring you in again. Looking at the figures, what was it? There was a lot of talk about investment in, again, as expected and as ever, in hospitals, talking about how we can build new hospitals and improve them. And it was just 559 million allocated to support the modernisation of technology across the system. If we're moving to more remote models of care, with that introduction of technology, but also the maintenance of technology is going to be crucial going forwards. But is there enough in what we heard yesterday for general practice estate, general practice technology? Because it's not all about hospitals, is it?
No, and I think you're absolutely right there, Gary. It was distinctly underwhelming reading the full spending review report yesterday, and I did what Bex did, trying to find general practice in there, and it was mentioned only once in the whole of the review. And there's certainly no funding that's highlighted there for infrastructure. When we asked the profession the question last year, this was before the notion of COVID even started, only 50% of GP practices felt their premises were suitable for their current needs. That was in 2019. And 80% of practices felt that their premises weren't really suitable for the future expansion. As Simon mentioned earlier on, we are looking at increased numbers of GP trainees, both in real numbers as well as the amount of time they spend in general practice. And there's a plan to increase the workforce both from GPs and the allied professional roles within general practice through the primary care networks. All of those workforce need space to work in. I think this notion of remote working means we need less space in general practice is absolutely nonsense. What's COVID shown that is we need quick change and proper investment and sustainable investment in premises, infrastructure and technology in general practice so that we can provide care to patients in an innovative way. But if we weren't even ready before COVID for the government to commit to spending on premises and infrastructure in general practice, yes, there was an opportunity and an opportunity lost by the government again to not make a positive noises about investment in infrastructure. We were asking for £1 billion at least to start this off. And there was, I think, absolutely nothing in there for general practice premises. And that's a huge concern for us, both in the short and medium term.
Okay, brilliant. Thanks, Chris. I'm going to come to Simon in a moment to see if he wants to add anything on that, because that training angle and the expansion of the team is obviously really important. But I think it's just really important to say at this point, that point you made about everyone assuming because we've gone remote that we don't need estates. I mean, we've been saying throughout the pandemic at the college that general practice is open, and we've still been seeing people face to face when it added clinical value and when it was safe to do so. So it's really important that we have modern purpose-built premises to allow us to provide the high level of care that we want to for our patients. But Simon, over to you, please.
Yeah, thank you. Firstly, I totally agree with you, Gary. When I started out in general practice, about 1 in 3 patients was complex, but now they all are, because other members of the team have taken on so much of the work. So actually that flexibility, I actually need longer with patients to give them the quality of care. So it's not suddenly going to be that my consulting room is available more. In my practice, we've converted so many parts of the building to consulting rooms now that one of the cupboards has been converted. I think we really do need the space. If you just look at a few of the numbers, GP training used to recruit 2,700 and they used to spend 18 months in practice. We're now going to be recruiting 4,000 and they're going to spend 24 months in general practice. That's 8,000 trainees needing space to consult. Add to that the 26,000 or more wider workforce. Add to that the trainees that are doing that. That's a massive expansion in estate needed. Even if we've got some degree of flexibility, you still need computer access. I mean, and Paul's Wi-Fi hasn't necessarily held up for some of his responses today. When you're getting on that with calls and you're calling a patient and your signal drops or system 1 crashes remotely, it all needs addressing, and we do need the estate to do it. And actually, I don't begrudge the hospitals getting some estate. My local hospital certainly needs it. But it's time for general practice to get some investment. And I'd love to hear an announcement when instead of schools and hospitals, it's practices and community hubs.
Brilliant. Okay, so in a moment, I'm going to go over to Bex to talk about another bit of technology and care, and that's around diagnostics. But first, Paul, perhaps I can come on to you just to see if you've got anything to add to that last question, please.
Yeah, I was just going to say that there are actually some opportunities to change the way that we use our estate as well. If we're moving to remote, then first of all, perhaps we might want to be working together in teams more rather than having separate rooms for everybody. I've seen really good primary care services in other parts of the world that design the estate so that the team stays together doing much of its remote work and then moves just into consultation rooms in order to see patients. And then the other big opportunity here is that we have many of these technological solutions have been solutions in search of a problem. Well, we've now got the problem, which is we're working remotely, and really I was very surprised that such a tech-savvy Secretary of State for Health hasn't really used this crisis in order to make massive investments in some of these remote technologies that enable people to manage long-term conditions better from home. I think there's a huge opportunity there.
Brilliant, thank you very much. So Bex, over to you on diagnostics, and I've got another statistic here. 10 times as many patients are waiting more than 6 weeks for diagnostic tests than in 2019. And RCGP estimates that establishing just one diagnostic hub per primary care network could deliver more than 12 million x-rays a year, which exceeds the elective x-ray capacity in 1819. Allowing primary care to take on some of this work would obviously have a workload impact, but it would allow us to work patients up more before making referrals in, give patients more choice, and potentially reduce workload over the system and give patients more choice about where they go for their diagnostics. There's been 325 million pledged for diagnostics, but like the rest of the review, it was all focused around hospital diagnostics. So how are we going to deal with this? How are we going to get diagnostics out into the community, and why is that important?
I think this is a discussion that we really need to be having. I think members may have seen Professor Sir Mike Richards' recent report on diagnostics calling for community diagnostic hubs, and lots of us, I think, will have thoughts about whether we could host those, how we could host those, and some of the benefits that they might bring for our patients. I think we need to think about that a little bit more. That needs to be locally directed. But the question that yesterday raised is, well, where is that money earmarked for? Like, I think there's a very real risk. The UK lags right at the bottom of the OECD for the number of CT scanners and MRI scanners, and the scanners that we have are horrifically old. And so there's no question that money is needed. There's no question that money is needed to upgrade the scanners we have at the moment. So I guess my thoughts are, if that's just an upgrade, then where does that leave the money for rapid diagnostic centres? And then if there were to be money for rapid diagnostic standards, how do we as a community in general practice work with our patients, with our communities, to understand how we would use money were it to become available to actually make sure that those centres work for patients? I don't think I currently have a clear view on that. Others may do.
Yeah, and I think that's really important, isn't it? Because a lot of these have knock-on impacts for the way not only we work, but how we manage workload and how we engage with patients and how they access their healthcare. I just want to take one question from Twitter, which is on a completely different area altogether. It's regarding the NHS 111 calls. And we've got a question from Katie on Twitter saying, how will GPs be informed and funded to take on NHS 111 calls before it's rolled out? And we've had another question along similar lines that's saying, do we agree that 111 first must not be rolled out without NHSE first releasing pilot data to inform GPs what proportion of A&E calls they should expect to receive during core hours? And what funding and workforce must be provided to GPs to follow the extra workload? So I'll probably go to you, Krish, on that one first, if I may.
Sure, Gary, and I share the concerns expressed by our GP colleagues. I think certainly, as a principle of trying to get somebody seen at the right place the first time, you can't dispute that at all. If someone is attending A&E and they will actually need to be in general practice, or vice versa, that needs to happen. We certainly need to work on that. But the concerns are, I think, firstly, there have been some pilots along these lines, certainly from earlier on this year. We really need to look at what the pilots have shown with respect to data and if patients are getting the right help when they need it, or are they simply being moved from one part of the system to another when the whole system is working at maximum capacity? And the issues always end up being that how will that patient journey be streamlined so that they're not left going between different parts of that? And how will you make a remote assessment on somebody and say it's not an emergency? And what happens if that person then turns up at the wrong part of the system and don't necessarily get the healthcare that they need? So I think colleagues having concerns on this is absolutely fair. What we need to be able to do is to design systems that work. Using a real example, most of us can relate to a time if somebody who has problems early on in their pregnancy would have been referred to A&E in early years. So since then, early pregnancy assessment unit came into place. That's not about redirecting somebody from A&E back into GP to then be sent to gynae. It's about having a system, irrespective of where that patient presents, they can be directed to the right place and getting the right help. Now, we can't really look at any area where there isn't an EPAU set up to support those women who have significant concerns and problems early on in pregnancy. That's the kind of systems and support we need to be looking at, not simply adding another level of triage and moving people from A to B, then to return to C, and then it actually increases the workload and the amount of things that need to happen before that person actually gets help.
Okay, brilliant. Thank you very much. And it's really important, isn't it, for our patients that as different access channels open up, we need to make sure that they do get the care they need in an appropriate fashion, in an appropriate place, at the appropriate time, because the worst thing for patients is when they start getting kicked around the system and they have numerous touch points. And that's bad for patients, but it's inefficient for the system as well. I'd just like to move on to something else now, which is a passion of mine. Another part of my portfolio here at the college is around the climate emergency and sustainability. And I think as we sort of move through probably the biggest public health emergency with COVID, there's others that will say that the climate emergency is equally as important. And there was talk from the government earlier on about, as we emerge and we restore services and we invest going forwards, that this could be done in a way that sustainability was at the front of our thoughts. But I just get the views from the panel on whether we've achieved that. Some will say we can't afford to invest along those lines, and others will say the cost is too much not to invest down those lines in terms of future health of the population. So who shall I go to first to ask that one? Maybe Sarah, if I could ask you. Thank you.
Well, if you look at the amount of funding that's going into active travel, which has been a passion of mine when I was in Parliament, it's risible compared to the scale of what we could achieve if we really were, for example, to put a fraction of what we put into HS2, or even to building a tunnel under Stonehenge, into really rolling out safe cycling. Because if you build safe infrastructure, people do use it, and we could have a system that looks much closer to Holland if we were prepared to properly invest in it, and we're not there yet.
Okay, thank you very much. And Chris, I'm going to come to you because in a similar way to RCGP Council has just passed our 10-point plan around sustainability, I know the BMA have been doing work in this area as well. Perhaps you could tell us a bit about that.
Yes, thanks, Gary. We did look at this area in much more detail earlier on in the year, just as COVID was starting, and produced a report about environmentally friendly and sustainable general practice. And if I may plug Sheffield GPs, Artie Bansal and Honey Smith, who started the initiative, and colleagues who are listening to this, please do visit the Greener General Practice website as well, where they started off about simple things that we can change as professionals in our day-to-day practice that make an impact on the environment. Things like how different inhalers have different carbon footprints. Some of us don't even realize that. Before I started looking at it, I didn't understand the full extent of that, and that's about information. But also the policy change. Our asks have been very clear. We want to make sure that general practice estate is carbon neutral by 2030. That's one of our biggest asks. And leading on from the earlier discussion about premises, that requires the government to fund GP premises so that we can lead the charge on making healthcare a sustainable and environmentally friendly way of doing things. And on top of that, there's many different areas about not necessarily relying completely on pharmaceuticals for management of chronic health conditions. There's a huge role for social prescribing and supporting people through physical activity, lifestyle changes, as well as much wider determinants that are negatively impacted by kind of leading the lifestyle and not being as carbon friendly as one could be. And it is an absolute passion of ours, and we'd really welcome colleagues' support to try and get what's a plan on paper into reality in the next decade.
Excellent, thank you. And thank you for plugging the Greener Practice website. As you say, fantastic resource there that's closely aligned to the work that the college is doing, but also a huge number of resources on the RCGP website now. So colleagues out there that are interested, I'll urge you to go to the website to look and see what we're doing in this area, because it really is very, very important. I just want to take us forward another couple of big areas that I want to touch on. First of all, around social care, and then perhaps around Brexit, because I think both of those are big issues. Social care got quite a complex funding settlement with £1 billion guaranteed from this year and another £1 billion for the next. But I think one area that shone through in the early part of the pandemic was the vulnerability of the care home sector and the patients that are living in our care homes. And again, things were slow to start with, but actually general practice, and I can talk about, the work some of my GP colleagues in Cambridgeshire have been doing to go into the care homes, and the level of care that's been provided has been absolutely fantastic. And again, that's another thing I think we can celebrate as a profession. But in terms of social care, was that enough money? Should we be doing more? Paul, can I go to you firstly on that one?
Yeah, thank you. So I think we also need to give a huge shout out for all of the workers in social care. They have been the absolute heroes of this pandemic, many of them working in unbearably difficult emotional and physical conditions, and many of them were late to get the PPE as well. Your question, Gary, was this enough money? I'm afraid it wasn't. We've been waiting for years and years and years for government to come up with a long-term funding solution to social care. And when Boris Johnson became Prime Minister, he said he had something ready, but we're still waiting for the political announcement. And there are some political choices to be made about not only how we properly fund it to deal with the instability that exists in the market. Providers often don't get enough money to be able to be sustainable. The low pay, poor working conditions of many of the staff, the demographic changes that are going to mean that we're going to need to fund more and more social care over the next 5 or 10 years. And also the entitlement issues, the fact that only those with the very highest level of need get free social care. there are estimates that we should be talking about an extra £11 billion worth of funding that's needed within the next year or two, and what we've got is a kind of rollover of the sticking plaster that we've had of giving an extra billion, and then this issue about allowing councils to raise council tax. They're allowed to, and this has happened over previous years as well. They're allowed to put an extra 3% precept on council tax to pay for social care, but of course, many of the areas of the country with the greatest need for social care are also some of the poorest areas, and the local authorities aren't able to generate that much revenue from their council tax in order to plug gaps. So this needs a big long-term solution. Sarah and I looked at it when we were both members of the Health and Social Care Select Committee, and I expect she'll probably want to talk about what some of those solutions might look like.
Yeah, thank you. And that's a lovely segue, Paul, over to Sarah. So Sarah, over to you, please.
And the other point I'd like to add to Paul's is the impact of Brexit, which you referred to, and you referred to them both together. The social care sector is particularly vulnerable to the impact of their future recruitment of their workforce because of Brexit and because of the changes to the immigration rules. And this is a sector that is on very low wage. 90% of the people working in social care are effectively being paid below the real living wage, and as, for example, the NHS gets an uplift, quite rightly so. That was one of the encouraging things about the provisions about the pay freeze is not going to apply to NHS staff, but it does have the impact of creating an even greater gulf between pay within the social care sector and the NHS sector. And so we're going to lose even more skilled nursing staff possibly from social care. And so I think that there will be a really serious deepening of the workforce crisis in social care next year if we're not very careful. And as Paul has said, there have been so many reports now on what the possible solutions could be to social care. I've lost count of the number of times I've heard that we'll have a solution next year, and it never comes because it's too difficult. The choices essentially involve people being prepared to pay more and sharing the risk. And we know that the majority of people will take a view is that they'd rather take the risk and not have to pay more. But we can't keep ducking this. I'm afraid it just simply can't continue as it is.
Yeah, and as is often the case, the politically most difficult thing to do are the ones that are really very, very important. There's just one other area I'd like to pick up and maybe come to you on this one, Simon. When we think about social care, we often think about people towards the end of their years in care homes, but we know that there's a huge amount of money spent in social care on working age adults. But I particularly want to ask you about the effect it has on the poorest children in society. I just wondered if you had anything you'd like to say around that, please.
Thank you. Yes, of course, being a GP in Northampton, my practice is just down the road from the county council that has the dubious honour of being the first council to go bankrupt. And the reduction in local government funding over many years has really impacted on services, and our children's services went into special measures. And it's the poorest children that need that support. And the loss of safe places for them to go is an issue. Early on in lockdown, I was talking to a mother who was desperate. She'd got a child with autism. They were living on the 7th floor of a tower block. And she couldn't go out, she couldn't get her shopping, she couldn't afford to do anything. And it's people in those situations that need the social services that our councils offer to step in and help them. And I think we can be judged by how we look after the most disadvantaged in our society. And at the two ends of the spectrum, I see poverty and I see loneliness. And I think there's a lot more that we could do to help.
Brilliant. Thank you, Simon. I just want to take up on another aspect of Brexit as well, and that's particularly around research. One element of the college work that's expanded massively over the last 9 months is our research surveillance centre. We've now got 1,700 practices signed up as part of that. And we've been saying for a number of years at the college that getting an academic research base within primary care is really important, and there seems to be a real appetite amongst colleagues out there to be part of that research now. But I know there's a lot of concern that with Brexit we'll lose funding into research. Now, I said earlier, the Chancellor pledged that he was going to make the UK a scientific superpower with £15 billion for research. But perhaps I could go to Bex on this one. Have you got any views on how we maintain research in primary care going forwards and the potentially negative effect of Brexit on that?
Look, I think there's part of it that is celebrating the strength to begin with, and I think that that will probably continue independent of Brexit. There will be people, I'm sure, watching this who are part of academic primary care units, who are involved in the college's research and surveillance centre. I was an academic trainee in Oxford back in the day, and there was a hugely active primary care community in research in this country. I think that will continue unquestionably, but I also think you're absolutely right. There are huge concerns about the impact of Brexit on research, anything from big research grants to how easy it will be for us to collaborate with European neighbours, also what happens to UK trial participants who are currently enrolled in trials based in the EU. To the best of my knowledge, we don't have answers to those questions yet. I'm afraid I don't know the answer as to whether 15 billion is enough to plug that gap. I think something that I felt was conspicuously absent in yesterday's spending review really was a proper analysis of the impact of Brexit. I think we were talking earlier before we came online about the sort of staggering nature of the UK's debt at the moment and the ratio of debt to GDP, which is just horrifying. I'll let Sarah jump in with her fun fact on that in a moment, but I think the point is we don't know how much is enough. I don't know whether 15 billion is enough, and I'm not sure that government really has a handle on that either, because I think, is it 36 working days to go now? It may be even fewer. There are just still so many unknowns, aren't there?
Yeah, absolutely. So I'm going to move away from the research, and I will come to you, Sarah. So we'll have your fun fact in a moment, but I was just wondering if you could just talk a little bit around, because there's going to be some very short-term effects of Brexit, one assumes, on the economy, but then some long-term impacts on healthcare going forwards because of the economic threats related to it. So I wonder if you could pick up that element first and then take us into the last 10 minutes with your fun fact.
Well, I think the scale of the national debt is just eye-watering. I mean, it is 2.2 trillion is our national debt now. And that is going to have an impact further down the line on what is available to spend on health. But I think the wider impact of Brexit in the short term, if there isn't a deal by the beginning of January, well, the impact on importing medicines, for example, and devices from the EU and the impact of those just-in-time supply chains, I think will be extraordinary. And also, of course, the knock-on effect on GP workloads, if those aren't available and you're having to sort out alternatives. I mean, we know the chaos it causes, for example, when there's a shortage in supply chain of any individual product. So imagine that on a much wider scale. So I think that is going to be quite extraordinary if they don't manage to come to an arrangement very soon. And of course, then, as I say, there's the wider impact on the workforce and the tragedy of the loss of the EMA, the European Medicines Agency, and the knock-on effect that has had across science and research with companies hemorrhaging across to the European Union. So I think that the longer-term fallout from Brexit will be profound across the NHS.
Excellent, thank you very much. And Paul, I'm going to ask you a question around the potential impact in particular for Northern Ireland colleagues and Brexit.
Yeah, this is something that I only really learned when I became a Member of Parliament and started to get immersed in the detail of Brexit. But colleagues that are listening from Northern Ireland will know this really well. But the health service from Northern Ireland and the Republic of Ireland, because of the geography and the fact that there is no border there, patients move from one country to the next, staff move from one country to the next, and we face the real prospect, if we don't get the right deal, of different regulations in different countries, and some patients missing out, some doctors having to change their referral patterns, all the previous agreements. It's been seamless, and there's been a really good service for really good NHS working between the two countries. It introduces a huge level of complexity, and nobody really knows. It's not 36 working days. It's I think it's less than 36 days until the beginning of January, and nobody really knows what things are going to look like.
Yeah, and it's like everything else we've discussed this evening, isn't it? The complexities that underline the headlines and the statements are phenomenally difficult to pick our way through. Amazingly, we've nearly used up the whole hour already, so I'm going to come to some concluding comments from each of you, if I may. I mean, COVID-19 has ripped through our communities, and we've highlighted some of the areas and folk who have suffered the most, and we've celebrated the response of general practice, health and care workers through here. And there was £1.5 billion pledged to help ease existing pressures within the NHS caused by COVID-19, but it wasn't particularly clear what that money was to be used for. So I'm going to go round each of you, and perhaps a minute from each of you on how you'd spend that money to help relieve those pressures that COVID-19's brought. Where do you think it could have most impact? I'll start with Simon, if I may. Oh, I thought Simon was looking thoughtful, but I think he may have frozen there. So we'll go to Krish.
Thank you, Gary. So where would I invest that? I think firstly, it'd be fair to say that the government has been very consistent throughout COVID in how they supported the nation. So consistently inconsistent is what I actually mean throughout the last few months. They haven't invested in public health appropriately. They haven't invested in social care. They haven't addressed the health inequalities and trying to support the most vulnerable of our communities. And they certainly haven't invested in people. I think those are the kind of areas that there really needed to be a serious conversation and investment in. And I'm afraid I think they failed on all those counts in the last few months. And the announcements yesterday didn't really show any indication of that changing in the coming few weeks to months.
Okay, thank you very much. And the same question to you, Paul, if I may.
So there are two kind of numbers that stand out for me that I think we need to be investing to try and help. One is the number of people who are unemployed by the middle of next year, 2.6 million, and the impact that that's going to have on their health. The impact also that that's going to have on general practice, because we know of all the health consequences of not being in work. The other big number that stands out for me is the number of people on NHS waiting lists. 4.3 million people currently on NHS waiting lists. 40% of them waiting for more than 18 weeks. 1 in 30 of them waiting for more than a year. And if we're going to look to recover the situation, we need to be seriously investing in waiting list initiatives. And this is at a time when the NHS, by the fact that everything has to be cleaned, the fact that different teams have to look after different people, the productivity of the NHS has been reduced by at least 5% because of that. So my investments are in public health, in getting rid of the backlog, and in the protection and support that staff need in order to be able to deal with those huge challenges.
Brilliant. Okay, thank you. And Simon, I'll come back to you. I think we lost you. I'd just ask you the question that of the 1.5 billion that has been put aside to help us recover from COVID, where would you spend it to help us in the recovery phase immediately? Where do you think it could be best spent?
Thank you, Gary. I would want to make sure that some of it went on looking after the well-being of the workforce. We can do no end to recruit more, but we actually have to retain the workforce and keep them productive. If they're exhausted, and at the moment I believe we all are, the emotional fuel tanks are depleted, and we were stressed and burnt out before it. So I really would like some resources to help the workforce, because we need it to be sufficient and sustainable.
Okay, thank you. And Bex?
Thanks, Gary. I think I'm echoing Paul and Simon, really. Paul's point about NHS productivity, I think, it's the nail on the head. We've got this huge backlog. Productivity has gone down. we estimate at the foundation that we're going to need about an 11% increase in activity, and clearly to even get our waiting lists back to where they were pre-pandemic, which, let's face it, weren't ideal. We all know that ricochets into general practice as well. And we simply don't have the workforce to achieve an 11% increase in activity. So I would certainly put some of the 1.5 billion into workforce. One final point I'd like to make, my kind of Christmas wish is that wherever that money goes, it's equitably distributed, not equally distributed. Because whilst we maintain this equal distribution and we fail to look at where need is and to distribute funding in proportion to need, we will just widen the gaps that have been there for so long and are just being exacerbated by COVID. So equity would be my kind of Christmas wish.
Brilliant, thank you, Bex. And I'm pretty sure there's a whole chunk of the audience that share that Christmas wish with you. Sarah, please.
And I absolutely agree that it has to be about the workforce. And yes, we need to have a strong focus on the new workforce that we grow, but they take years to come on stream. We have to retain the workforce and focus on workforce wellbeing if we're going to be able to tackle this.
Brilliant, thank you very much. So I'm going to have to draw things to a close now. Thank you to the panel for your words of wisdom tonight. Fascinating discussion that could quite happily have gone on for another hour. This will be immediately available on YouTube for people to watch again. Our next event will be talking about COVID vaccination and how we're going to roll that out. We'll make sure that any resources that have been referred to tonight from the BMA and the Health Foundation are on our website, and we'll also post them out through social media. But thank you again to everybody for watching. Thank you again to my panel, and I look forward to seeing you again next time. Thank you for everything you're doing. We've heard about the things we should be celebrating, and although tonight was all about the money, as ever, it's about the people that it impacts. So thank you all ever so much. See you again soon, and enjoy the rest of your evening. Goodbye.
Good evening.